I'm Giuseppe Rosano. I'm professor of cardiology at St. George's Hospital in London, and I will discuss with you today how to manage obesity in the cardio renal metabolic syndrome. So we know that obesity is a global pandemic and has a high prevalence that is increasing and is associated with several complications. They are mental, metabolic, but also mechanical due to the effect of body weight on joints. And we also know that the progressive weight loss has important biological effects. But also, I will show you that weight loss is associated with a metabolic adaptation, with changes in hormones that induce fullness and increase in hormones that induce hunger. And this is why there's a need for a comprehensive intervention in these patients. So there's no doubt that obesity is increasing worldwide, it's increasing rapidly. It's increasing more in some regions, and we know the effect and the importance in Middle East and North Africa, how that is very prevalent and fastly increasing. So that is something that should be tackled without delay. The problem is that often remains undiagnosed and undertreated, because if we look at the people living with obesity, only less than 40% are diagnosed, less than 20% receive treatment, and only 1 to 3% are prescribed anti-obese medication. So it's the number of patients prescribed and are treated is only minimal compared to the overall number of patients. The other problem is that often there are very few patients who start to lose weight, and of those who start losing weight, only a minority, 10%, maintain the weight loss over 1 year. And the same is perceived by the physicians. In fact, only 35% consider that patients are really making changes in order to lose weight. And what is important is that only 30% are supportive in weight loss. However, we have to take into account that obesity is associated with multiple complications, from cancer to cardiovascular disease, coronary heart failure, coronary artery disease, heart failure, and type 2 diabetes, non-alcoholic liver disease, fatty liver disease, and infertility, but also with respiratory problems like asthma, sleep apnea, and arthritic problems like chronic back pain, incontinence, knee arthritis. And also is associated with cognitive issues, so like depression because of the increase in body weight and the anxiety. We also know that people who lose weight have changed in hormone levels. As I said earlier, there's an increase in hunger hormones and a decrease in hormones that induce satiety, and a decrease in hormone expenditure that leads to weight regain. And we know that often patients lose weight and have a significant effect on weight loss, and then tend to lose this effect, and that is associated with the effect on hunger and a desire to eat, and that is progressively more important in individual who keep that the weight loss for a longer time. Also, when we have body weight loss, we see that together with the weight loss, there is a decrease in the resting metabolic rate, and patients who lose weight tend to have a less expenditure. So they need to eat less and less in order to maintain that weight loss. When we look at the complications, you see that there's a galaxy of complications, of which some are very important, like hypertension, coronary artery disease, type 2 diabetes, heart failure, and cancers. and others less important. And they are very prevalent, as if we see patients with obesity, 20% of myocardial infarction, 40% causes, 50% hypertension or a knee osteoarthritis, together with all the other problems like patients with that develop diabetes or an NAFLD. When, however, we can see patients who are obese and never develop any disease because there are patients who are metabolic healthy with obesity. And in these patients, their risk of future events, apart from type 2 diabetes, it's lower. And then patients who are obese and are metabolic unhealthy. And you can see that those with who are metabolic unhealthy then have a significantly greater future risk of events. But in any case, those who are metabolic healthy and metabolic unhealthy, all of them have a significantly greater risk of developing diabetes. And as you can see, the risk of developing diabetes increases by a BMI of 27, 28, which is still normal, and increases to 90% in those with a BMI that is greater than 35. So there is a benefit of early intervention because an early intervention in diabetes decreases significantly the risk of type 2 diabetes, sleep apnea, both of them by 5-folds, osteoarthritis, and heart failure. So it is important to have an early intervention. We have evidence from clinical trials that weight loss reduces by 34%, up to 34%, the risk of type 2 diabetes over 10 years, regardless on how the weight loss has been achieved with metformin, with lifestyle changes, with gastric surgery. And we know that in patients with obese with type 2 diabetes, those who undergo bariatric surgery tend to have a remission of their diabetes, and this is consistent in all the different studies. So the progressive weight loss has a dose-dependent biological effects on liver, triglycerides, glucose metabolism, insulin sensitivity, and inflammatory markers, but also has an effect on the development of heart failure with preserved ejection fraction, as we see that heart failure with preserved ejection fraction increases in above the BMI of 27. There are several mechanisms that may explain why patients with obesity may develop heart failure with preserved ejection fraction. In part are due to the hormonal activation, like the renin and aldosterone system, the leptin, increasing plasma volume, cardiac fibrosis, all of which lead to an increase in stiffness and feeling pressure. And the weight loss has been shown to have an effect on heart failure with preserved ejection fraction, and this is regardless on the type of exercise of weight loss, either induced with exercise or with diet. Together with the decreased risk of heart failure with preserved ejection fraction, weight loss also improves the cardiovascular risk markers, it decreases blood pressure, normalizes blood lipids, especially triglycerides and non-HDL cholesterol, reduces glucose, and increases insulin resistance. So when we see how we need to approach patients with obesity, of course, when patients with a BMI above 30, we need to have either pharmacotherapy or surgery if the medical therapy has not worked. In patients with overweight but have adiposity-related complications, then we need to use pharmacotherapy. And this is supported by the different guidelines, all of which suggest that apart from those with a high BMI where we need to use immediately a surgical option, in all the others, we need to have a behavioral therapy and pharmacological therapy prior to go to surgery. And we know that the pharmacotherapy, in addition to diet, is effective in reducing a significant weight loss. It can achieve up to 12% of weight loss. But also we know that the medications are rarely prescribed in patients who may need it, and only 3.4% of patients who are eligible with a BMI of 40 are prescribed with drugs. Now, and this is very important because now we have new drugs that are very effective in reducing body weight. One of these is the semaglutide. That is a human GLP-1 analog. That is a 98% homology to the human GLP-1, has a direct effect on the sense of hunger, has a direct effect centrally on the brain, but also reduces appetite. And this is due to the fact that the GLP-1 secretion and expression is widespread. It's all not just present in the brain, but also the GLP-1 agonists, receptor agonists, have an effect on several different organs. But as far as obesity is related, we know that the GLP-1 increases the satiety, so the feel of fullness, and reduces hunger in even in normal weight subjects. And in normal weight subjects, as also reduces hunger, increases the sense of fullness, and as an appetite suppression. Very important. So semaglutide has been tested in several studies. Patients with different range of BMI, patients who have different ages, roughly with a mean age ranging from 30 to 75 years. And you can see that in all of them, there's been a significant change in body weight up to 15%. But that decrease in body weight was associated with a significant decrease in glycemic parameters, decrease in HbA1c, decrease in fasting glucose, positive changes in blood pressure with a decrease in blood pressure, and therefore now we need to look at semaglutide as the preferential approach for weight loss in patients with obesity. Of course, we can consider other options, but all the other options have side effects and also central effect on that may limit their use. So it's important to recognize patients who need to be treated and treat them properly and promptly.